All right, everybody. Thank you so much. Again, just want to give a shout out to all the sites that Michelle just recognized. It's amazing work. I am going to talk through in this next section the pediatric asthma care bundle that we will be implementing for a new performance measure starting in the 2026 paper performance year. Like Keith mentioned, we've reviewed this a little bit with our executive committee, a little bit with our pediatric committee. This will be the first time we're talking about it to the entire collaborative. If you have questions, we might have a little bit of time. I'm going to try to go through this relatively quickly to keep us on track here for the day. But the one thing I will say is if you have sites questions that are a little bit more specific to your site, might be better for a message or an email after the fact. Happy to review this. And we've got time to answer your questions over the next few months as well. So just talking through the goal of the asthma care bundle here is to just, similar to our other performance measures, utilize the data that we have and use our evidence-based pediatric asthma care in the ED. I will say the foundation of this evidence is not new. The tools that we have on our website have been there since even before I joined Medic. We have not changed those at all. All of those things that we've been promoting in the care of asthma patients is the same. We're just grading it a little bit differently. So that's kind of like what we're going to be talking through today. So our target population includes patients with an ICD diagnostic code for asthma. That is not new, and patients between the ages of 2 and 18. Again, we've talked about this a little bit before. We sample up to 125 asthma cases per site per month. This hasn't changed since last year. This sampling approach is really so that we're not sampling anymore. Most sites, we are getting all of your asthma cases with the exception of the pediatric hospitals in peak respiratory season. So for all sites, we should have, or for most sites, we have all of your asthma cases with the exception of the ped sites for a couple of months. We will be talking or focusing on kids with otherwise medically uncomplicated asthma, which is a little bit of a change for us. Patients in the ED that are experiencing acute asthma exacerbation and patients of all dispositions. So discharged, admitted, transferred, other will be included in the performance grading for this measure. Some exclusions to note. So patients that come in with an ESI or acuity score of 5, they will be excluded, and patients that do not receive albuterol or steroids in the ED or prior to arrival, just trying to eliminate the cases that were unlikely to be a true asthma exacerbation. And then kids with any of the following things in their past medical history will be excluded, again, trying to focus on those uncomplicated asthma patients as much as possible. A couple things to note. So we will be adding an option for the abstractors to note when a patient has tracheolaryngeal or bronchomalacia. We currently have an option for other with a free text option for the abstractors to include. We did a whole deep dive into the data, and the malasias are the most common thing that we see there. And a lot of the other stuff that we're capturing are things we don't really intend to capture. So what we're doing is we're adding the Malaysia option for abstraction, and we're actually removing the other category. Abstractors, no, this has not happened yet. It will be happening likely with the next release. We'll keep you posted on that. And then we will still be abstracting whether or not patients are premature, so less than 37 weeks gestation, but it will not be an exclusion for this measure because we feel like being premature does not preclude a child from receiving standard asthma treatment in the ER. And the last exclusion for this performance measure is if they have an ED disposition of AMA or left without being seen. That is a new exclusion for all of our performance measures. We don't even abstract those cases anymore. This is the beginning of the flow diagram, which we will add to our website. So to receive credit for this new asthma care bundle, a patient must meet, or a case must meet all 3 bundle criteria, which we will talk through here in just a moment. Why are we asking for y'all to meet 3 out of 3 bundle criteria? One, it's a little bit easier to explain, and logistically, it's a little bit easier to calculate, but more importantly, it's a more complete measure of the gold standard of care for these patients. We've talked about this with, again, the PEDS committee a couple of times now. And it also allows us to give you credit for cases that don't necessarily require all 3 elements of the bundle, which we'll talk through a little bit more in the next few slides. I will say we're getting into the nitty-gritty in these next few slides. So again, if you have questions, please let us know. But we want to make sure that we're accounting for all different types of scenarios of patients presenting to the ER for asthma care. So the first bundle criteria, which is the most straightforward one we've been talking about for a little while now, is serial asthma score. So a case must have at least 2 documented asthma scores using a validated asthma tool. So PASS, RAD, PRAM, If you're using a homegrown tool, that's okay as long as you share that tool with us and we know that it's got the components of a clinically validated asthma assessment tool. Again, this is no change from what we've been talking about. Minimum of 2 scores. I will say, while this is the most straightforward piece of the bundle, I think it's where we have the most work to do. I think there are still many, many sites, I think over half of the sites in our collaborative who are not currently documenting asthma scores, and just know that once we start grading on this, if you're not documenting scores, you'll end up with a 0% on the performance measure. So something to keep in mind as we work towards this for the 2026 P4P year. Next up, so the second bundle criteria, one where I think hopefully most people are familiar with, is timely steroid administration. A case must meet one of the next 3 scenarios to receive the credit. Not all of them, just one of them. So the first being, if a patient does not receive steroids prior to arrival, but they do receive steroids in the ED for treatment of an acute asthma exacerbation, they have to receive those steroids within 60 minutes of arrival. This is not any different than our current time to steroids measure, holds us to that standard of early steroid administration. And this is going to be the most common scenario, the one we recommend emphasizing to your staff when you roll out this teaching. This is going to be greater than 80% of the cases that fall into this performance measure, right? Kids that come in, they haven't received any treatment yet. We're starting their treatment and their care for this acute exacerbation in the ER. The second way you can receive credit for timely steroid administration is if a patient receives oral, IV, or IM steroids within 24 hours of arrival to your ED, you get credit, right? We don't want to penalize providers for appropriately not repeating the steroid if that patient has already had them. So a couple of examples here quickly. A patient was seen in an outside hospital. They were given IV prednisolone before they were transferred to you. You guys don't need to worry about giving them another dose of steroids within 60 minutes. They got their steroids already. You're good to go. Again, a patient was seen at their PCP office. They were prescribed 2 doses of Decadron. They took the first at home. Mom decided kid's not getting any better, so they came to the ED within 24 hours of that dose. You do not have to give steroids within 60 minutes of arrival for that patient. It varies by site and the percentage of cases these are, but somewhere between 0 and 10% of your cases. So a small percentage, but just another way that you can receive credit for these cases. Lastly, I will say this is the most rare or uncommon, but again, we want to account for it. It does happen. If a patient does not receive steroids prior to arrival or while they are in the ER with you, but they do receive a bronchodilator for treatment of an acute asthma exacerbation. So we don't want to exclude these cases, right? Because these cases are getting appropriate asthma care. It's just been determined by the clinician that this patient does not need steroids for whatever reason. So a couple of examples of this, right? A patient is having a very mild asthma exacerbation. They're requiring breakthrough treatment of albuterol in your ER, but their symptoms are otherwise well controlled with their home QVAR. The clinician decides they don't need systemic steroids and just discharges them home with keep using your albuterol inhaler as needed. You get credit for this case, right? You don't have to worry about giving steroids within 60 minutes if they don't need them. Second case scenario, patient has a past medical history, including some type of contraindication for systemic steroid treatment, but they do get appropriate asthma care otherwise. They get the albuterol nebs, and then they're discharged home again with a prescription for albuterol, no systemic steroids before or during the ED encounter. You get credit for this case without having to give the steroids. Again, somewhere between 0 and 10% of the cases, I'd say this is the most rare scenario, but just want to make sure that you all know that we are accounting for these kind of like these nuances. And again, just kind of from the top, if they don't receive your steroids before arrival, they need them within 60 minutes. If they do receive them within 24 hours, you're good to go. And if they don't receive and don't need steroids at all, you're good to go. Bundle criteria number 3, our last bundle criteria here, timely bronchodilator administration. It has to meet one of the following 3 scenarios, similar to steroids, but a couple of differences. So if a patient does not receive a bronchodilator in a healthcare setting before they arrive to you, but they do receive a bronchodilator in the ED, it has to be within 60 minutes. Again, similar to our time to steroids, it holds us to that 60-minute of arrival timely bronchodilator administration. The one thing I want to point out here, though, is that bronchodilator must be given in a healthcare setting, right? This isn't mom giving Johnny his inhaler at home. This isn't Johnny using his neighbor's inhaler. This is patient got a bronchodilator at their PCP office, EMS, etc. So again, a couple of case examples. This is the most common scenario that we want to recommend emphasizing to your staff. greater than 80% of your cases. I think I got a little bit ahead of myself. This next one is where if a patient receives a bronchodilator in a healthcare setting before they arrive to you, you have up to 4 hours post arrival to give the patient their next bronchodilator. This way, we're not penalizing sites or providers for appropriately waiting, right, to give that next bronchodilator. Some examples here. Patient arrives via EMS, they got duonebs en route, they arrive with clear lung sounds, and they don't need albuterol for 2 hours. After they arrive to you, you get credit. Patient was given 5 milligrams of albuterol in an outside hospital before they were transferred to you. They arrive with clear lung sounds and they don't receive albuterol until they're discharged home 3 hours later. Both of those scenarios, the patient was given bronchodilator within a healthcare setting and they didn't require bronchodilator treatments immediately, but did get them within 4 hours of arrival to the ER. And then lastly, again, 0 to 10% of your cases, depending on, your site's patient population. Lastly, timely bronchodilator administration bundle criteria. If a patient does not receive a bronchodilator before they get to you in a healthcare setting, they don't receive one while they're with you, but they do receive steroids, right, for treatment of acute asthma exacerbation, you still get credit. This one I think is the most rare, but a case example. A patient is having a mild asthma exacerbation. They've been using their home albuterol inhaler 4 times daily. They arrive to you with clear lung sounds, but you do give them a dose of Decadron, right, for this acute asthma exacerbation that they're experiencing based on their history. And you instruct them to continue using their albuterol at home, but they don't require a dose of albuterol while they're in the ER. That you would still get credit for this case for meeting the appropriate asthma care. Again, 0 to 10% of your cases, this is really like 1 to 2% of the cases that are going to walk through your door. Those 3 options kind of out. We put all this in the slides so you guys have them to reference. I won't go through this again here. And then just note for the performance measure, your numerator of the performance measure is going to be cases that meet all 3 of those bundle criteria. The denominator are going to be all of your eligible cases. Again, your bundle criteria being there on the left. A couple things to note, there is no significant changes to obstruction required. We did all of that in preparation last year. Because nothing is changing, we will have baseline data back through April 2024. Our next step is getting that data into Tableau for you so y'all can start to look at and see your baseline data. And again, this is not new work. This has been part of our endorsed practice guidelines for asthma since before I joined back in 2020. So all the information that you need is available on the website. Again, think about over the next few months how to start priming the pump a little bit at your site for the things that we're going to be looking at starting in November of this year. We're going to be meeting with the executive committees this summer to talk through how, again, what the targets are going to be, things like that. And then starting in November of this year, we're going to be grading on this very exciting new asthma bundle. Questions? Yeah, I see the question in the chat about if this is going to be collaborative wide P for adult and peds. It's an excellent question. We're going to work through all of that with the executive committee come June, July. I will say that when we start new measures, we don't usually go more than 5, maybe 10 points on the scorecard, but all of those details and nuances will be worked out with the executive committee this summer. So good question, Andrea. If you haven't been using an asthma score, you will have baseline data to review. Your performance is going to show 0%, but you can dive in to see how many, like what your percentage is for each bundle criteria. So you can see how many of your patients are meeting the timely steroid administration and timely bronchodilator administration data. So you can start to work on those in conjunction of implementing asthma score documentation at your site. So while your performance will be 0%, you can dive into each 3 of those components to see how you're doing on each of them. Okay, sorry I talked through that quickly. Please email me if you have any questions. We want to make sure that everybody feels good about this before we go into the next performance here. We do have a 5-minute break. Andy, do we feel good coming back at about 10:46, or do you want to adjust that at all?
Let's make it a 4-minute break and come back at 10:45.
Okay, sounds good. We'll see everybody at 10:45. Grab some coffee and snacks because we've got we're hoping for some good engagement in the second half.
Hey, Megan,
Yes.
could you go over that second bundle for the pediatric asthma for the bronchodilator?
Sure. Let me pull it back up. I'll let Katie jump in because she is
Sure.
expert here. Any particular one of the scenarios?
Just the second scenario.
This
If-
one, I think.
Bron- Though.
Go to the
I'm sorry.
Sorry.
Bronchodilator.
Yep, so maybe scenario Y, I think. Yep, this one.
Exactly. Yep. Yep. They must receive a bronchodilator within 4 hours after ED arrival. So you're just looking for them to get a second bronchodilator treatment in
If
the ER.
Yep. So if they receive a second bronchodilator treatment in the ER after they've had one pre-hospital, then they just need it within 4 hours. So rather than requiring that bronchodilator is within 60 minutes, you've got up to 4 hours to get that second bronchodilator in because it might not be necessary to repeat that bronchodilator within those first 60 minutes.
Perfect. Thanks.
And again, reach out, folks. We know this is complicated. We went through it fast. That's why we're here. This is our job every day.